So as people are just trickling in, I just wanted to say welcome and good evening to everyone. Thanks for spending your evening with us and looking at this demo with us, and welcome to the professional staff kickoff for our program. So I did just want to highlight, this is the very beginning of a long project. It will be 2 years in the making here, and so it's exciting to sort of be in at the beginning and have the chance to really see some of the exciting things that will be coming our way, and some of the things where we may need to do a little bit of work to make the system do what we would like it to do, and to learn how to make it do that. So we have Dr. Derek Garnis with us tonight, and our CMIO, Steve Varioki, will give him a little bit more of an introduction in a moment. But I did want to bring everyone's attention as well this evening that we are also promoting our website is now live. So you'll see at the bottom of the screen the bridgenw.ca. So when you have a moment later on, you can go to that website and see some information and sign up to get some updates there. We are going to start with a Slido poll just quickly. So the first question is just asking what organization you're joining us from this evening. Well, I'm not sure if I can. Oh, there we go. That's better. Well, tried in. Nice. Good. Perfect. What I like about this poll is it gives us a chance to see, how the whole region is working together here. So colleagues from across all of Northwestern Ontario, and different sites, different sizes of sites, and everybody coming together to work on this initiative together. So I'll give about a few more seconds for people still trying to join in here. For those just joining us, we're just doing 2 quick Slido questions here, and then we'll get into the session this evening.
Pastor Jim, que na unye Saskatchewan where bien.
Perfect. I'm going to move to the next question. So the next question is about if you've ever used one of sort of what we call the big 3. So that being Expanse, Epic, or Cerner Oracle in the realm of electronic health records. We've done this poll a number of times with all of our leadership kickoff sessions and that, and we do find that it's a fairly new product for many of the people we've spoken to so far, but I suspect that with this group that might be a different answer, given that people have worked many different places and might have some very different experience. So yeah, 21 people so far, so we're at 49 participants, so just under half of people, with 71% saying have not used a system like this before. So it will be interesting to see what the system can do. Many people have used Epic or Cerner and less Expanse. So it'll be interesting to hear people's comparisons of the 2 systems as well. There will be some survey questions at the end using the Slido as well. So you can just sort of keep that open on the side or something. And there will be some questions at the end just asking a little bit for more of your feedback on the session. So I'm going to stop sharing that poll now. So thank you for participating in that. And I'm actually going to turn the floor over to our Chief Medical Information Officer, who is Dr. Steve Varioki, to introduce the program and the session. Thank you.
Great. Thank you all so much for coming. This demonstration live of Meditech Expanse has been the #1 request from clinicians in the region, and I'm really happy that we could make it happen tonight. My name is Stephen Viharioki. I'm a family doc in Dryden. I'm the physician face to this project and the Chief Medical Information Officer for the hospitals between Manitouwadge and the Manitoba border. I'm really happy to introduce Dr. Derek Garnis, who is an emerge physician and the Chief Medical Information Officer, my colleague from the east side of this. He has been through implementations in Sault Ste. Marie and North Bay, and then the second wave with Health Science North in Sudbury, and then the smaller hospitals in the region there. So he has done this several times now, is an expert on the system, and has been really been instrumental in helping us along the way and give us guidance and advice. And I'm also really looking forward to this demonstration. So thank you very much, Derek, for agreeing to do this and helping us out. And we won't hold you back. This is great.
Excellent, thank you. Did you want me to go ahead and start with the demonstration now then? Okay, I'm just going to share my screen here. Great, thank you for that. So welcome everybody. I'm quite excited to be here today to give you a demonstration of Meditech Expanse. I recall being in similar shoes back in 2015 or so when we were looking at upgrading our HIS system, having gone live in 2019 with Expanse with our first 3 hospital sites under one HITS, and then it's been a year now and the other 20 hospitals have gone live. So we have 23 hospitals live under one instance of Meditech Expanse. So I know how you feel. It's a scary time. It's a time of a lot of unknowns. It's a time of, wondering if this can actually even happen. Everybody feels like their hospitals are very unique, and they are very unique, and whether or not you can actually implement something like this. So it's a time of a lot of stress. Some people are very excited, some people are worried, some people are just angry and mad. So it's a time to learn and see what the system's about and to get involved. And I just want to stress that. I don't want to be going on a lot about change management and things like that, because you're going to get that a lot of that. But I just want to stress the importance of getting involved in the system. You need to get engaged and adopt the system and then be a steward of the system. So any opportunity you have to get involved as a subject matter expert or what have you, I highly recommend it, because the projects that have gone live, and I've seen many of them over many places in Ontario, the ones that are very successful are the ones that have had lots of physician, lots of provider, staff, nursing, everybody's involvement in the system. That's how it makes it successful. So we're going to dive right into the demonstration. What we're going to do tonight is we're going to follow 2 patients. One patient we're going to see in the emergency department and just kind of do some emergency medicine type stuff. And then the other patient we're going to see in the emergency department, but then we're going to admit the patient and follow the patient through their inpatient care. And then we're going to have some follow-up in the ambulatory care setting. So the idea is to kind of give you a nice picture of the continuity of care throughout the system, as well as kind of highlight some of the efficiency factors and things that you can do in the system to make things easy. It makes it quite easy for ordering and documenting. I just want to really show that it's not as onerous or scary as sometimes people can think it will be in the electronic world. All right, so this is Meditech Expanse. It's very different than Meditech Client Server or Magic, and it is a full revamp of the system, and it's web-based. So as you can see, I'm on an internet Google browser with the URL for Expanse, and it's being displayed in the Google browser. Since it's web-based, you can deploy this to any mobile device. So I'm on my desktop on my Mac right now. If I had my iPad, I could have it on my iPad and it would deploy perfectly to my iPad. because it's HTML, it's web-based. So that's one of the really nice aspects of the system, is that you can use it on a mobile device and it will deploy perfectly to the screen based on it being a web-based application. The system is designed so that it doesn't matter if you're in web acute, which is the ED part, or sorry, the web acute, which is the inpatient part, if you're in web ED for the emergency medicine aspects, or if you're in ambulatory for the ambulatory clinics, it looks the same throughout. It's got the same look and feel. And I want you to kind of keep an eye on that as you're going through as you see us go through the different modules, because the idea is that, once you've had familiarity with one aspect of the system, you can pretty much use all aspects of the system because the functionality is the same. You're using, the same patients, the same data, the same information. How you get into the patient's chart is the only thing that looks a little bit different. Once you're in the patient's chart, it's exactly the same. So that's a really important factor in this, because I can honestly hand this to people and say, find this patient, put in an order, document, and I guarantee you the majority of people would be able to do it without any training right now, because it's fairly intuitive. So this is the ED tracker. The screen is broken up so that you have some ability to kind of have information displayed in a way that's efficient. So here you can see part of my tracker for the patients that I've signed up to in the ED. Then I have my workload over here on the right-hand side of the column, and some of my documents that are pending here in the middle. I can expand my tracker so I see my full tracker, which is usually how I view mine. And on the top screen up here, this row, this home row, you see the chart button, the document, orders, and discharge. You're going to see that throughout every screen that we go into, because that's the key things that we do every day, right? We chart, we document, we place orders, and we discharge. So that's the key functionality. And then of course over here I have access to my workload. I can sign some documents, get help, things like that, as well as on the left-hand side have the ability to toggle between the different modules. So right now I'm in the ED department, and this is web ED. But if I needed to toggle over to the acute status board, which is to go see my inpatients, or if I wanted to toggle over to the ambulatory side of things, I could just simply hit that and toggle back and forth. And I'll show you that when we move into the inpatient side of things. So being able to quickly go from one area to the other, really important. On the tracker here, you see that these little buckets, these are buckets that hold our patients in categories. You're going to have the ability to decide how you want those buckets to look for your site. Even though the systems can be shared across all of your different hospitals, you will have the ability to customize this so that it follows the flow of your ED department. So here is my list. These are the patients that I've signed up to. And then I have patients in our fast track area of the ED, patients in our acute and subacute area that are waiting to be seen, and people in our see and treat area. And then there's multiple lists more, and I can decide how I want these to look. But for me, I want to know who I'm seeing right now and what patients are still out there for me to see. And of course, in our department, we have screens on the wall that emulate this so that you don't have to constantly look at individual trackers. You can see the information on the screens on the wall. So on the trackers, it provides all of the information that you need. I can put the column headers there if I wanted to see these and sort by these column headers. But essentially, I have my patient. I have how long the patient's been in the ED, and this is, of course, is the test system. So this patient here has been in here for a long, long time, but could represent most EDs these days. You see that the patient's here with, this one's here with hallucinations. I can see that I'm signed up to the patient. A little yellow sticky note for me to put my own personal notes on. And over here on the right-hand column, I have my investigations. So as I order investigations and as investigations come back, they're going to start populating this area of the tracker here. And I'm going to show you that in more detail when we sign up and follow a specific patient. The tracker will also give information such as if the home medications need to be reconciled. So I can hear this patient's here. Home medications have all been confirmed. This patient's home meds or the BPMH hasn't been done yet. All those kinds of things can be brought to the tracker so the appropriate person is aware that, hey, you need to get the BPMH, the best possible medication history in there, or yes, that BPMH is done. So now we can go to the med reconciliation. So the tracker can be customized to put what's important for your organization or for your department on this screen. You'll see this little sepsis indicator here, this little red sepsis indicator. The system has the ability to do surveillance in the background, so it can continuously wait and see for things to happen. So is the patient have a temperature and their white count goes up and their blood pressure drops, it'll give you the early warning system that there's a sepsis possibility in this patient. So you can set up surveillance to continuously monitor and look for things to happen and notify the provider when it does happen. So let's take a look at our patients to be seen over here. So I'm going to click on the See and Treat area. And now my first patient here, Test George. He's in room 29. He's been waiting about 7 hours, so we're getting a bit closer to the reality of the ED. He's registered. It says abdominal pain. And I can read the triage note here. So by clicking on this little red button, I'm going to see that this patient's coming in with 2 days of mild right lower quadrant abdominal discomfort. Reports pain is 3 out of 10. Has been unable to keep down any food or liquids in the past 24 hours, and he is diabetic. All right, so I see the patient's initial vitals here, 139/78, that they are low-grade fever. I'm going to go ahead and sign up to this patient. So by clicking on sign up, the patient is now going to populate my list over here. So I can see now this Test George is now on my list of patients to be seen. This patient, as you can see over here on the right-hand side, already has some investigations ordered. I see he's got some blood work done, some labs. He has a urine that's been ordered, but it's not been collected yet. And by seeing these indicators, I can tell when things are back or not. You have noticed probably now that I have yet to go into the patient's chart. So all this information is right here in front of me, so I don't have to go scrambling and looking around in and out of the chart. You shouldn't have to go in the chart unless you're looking for specific information or when the tracker is telling you something new has been posted or something new has gone on. So Test George, I can see the lab here is in yellow, something's abnormal. I can simply click on it and it's going to show me some of the blood work that's come back on Test George. So I can look at his white count, it's 12.2. I can scroll down and see his electrolytes, sodium's 135, the remaining electrolytes and liver function tests and what have you. I can also see that the urine down here has been uncollected, and it's been since 11 this morning. So, I need to chase down somebody to go get that urine. Now that I've seen those, now the lab indicator is turned off. So I know that there's nothing else new that's been posted on this patient from the lab perspective until it turns color again, such as here when you see the green with the yellow dot. So that's really nice. How did these labs and stuff get in there? Well, this patient obviously had a medical directive done when the patient presented to the ED. Medical directive was done. A lot of this stuff was ordered for me and ready to go. Let's jump into the patient's chart. So how do you get in the patient's chart? Well, you click the chart button at the top when they're highlighted. Or you can just double click on the patient's name. So there's multiple ways to get in the chart. Either double click on their name or just click on chart. So when I open the patient's chart, this is what it looks like. What I wanted to do really quickly now, just for the purposes of the demonstration, is normally what I will have is a chart viewer open as well. So when I open this chart, you'll now see on the left-hand side of the screen is my main chart that I'm working with. And on the right-hand side of the screen, this is called the chart viewer. So if I'm in the patient's chart and I'm looking at things and going between different tabs, like looking at provider notes or what have you, I can then be on this side of the screen, either looking at more information, or I could be placing orders on the patient while I'm over here doing things such as looking things up. So I could be looking up the patient's labs on this side while I'm over here placing orders. So I just wanted to show that quickly that you can have the chart viewer open to multitask. I'm going to close it now, only just for demonstration purposes, so that we have just one screen to worry about here. I just want to change one quick little thing here. Okay. All right. So back to the summary screen. When you go into Meditech Expanse, you're going to be provided with these tiles called widgets. And these widgets bring forward anything that's in the system and presents it to you so that you can have things at your fingertips. So I don't have to go digging through the chart under these different tabs up here, the provider notes or diagnostics or the nursing notes. That's all there if I want to go looking through it. But really what you want the system to do is bring forward what's important to you so that you don't have to go searching for it. The My widget is one key way of doing this. This is a demo system, obviously, but the My widget, I use this a lot. Most of our providers do. And what it does is it's going through the system, and anything I've told it to go look for, it's pulling it forward if it's available and displaying it for me right here. So I know that Test George, his hemoglobin is back today at 140. His platelet count is there. I can look at his last discharge summary from September the 25th. I can look at his last ED note. So simply by clicking on that, I can now go to the last emergency department note on this patient, or I can look at any of the emergency department notes on this patient. So it brings forward the most relevant one, or sorry, the most recent one, and then any other previous ones are listed here for ED notes. Similarly for the discharge or the discharge summary. So you can have it pull forward what's important for you: CT scans, X-rays, consult notes. In our orthopedics clinic, the orthopods want to see particular images and their previous surgical notes and things like that. So you can bring forward what's important to you. There's also many other widgets that are that come with the system that you can decide on using. For example, this widget shows me all the visits this patient's had in the past. This widget here shows me all the documentations on the patient. So these are all the documents that are on the patient in terms of categories, showing me the most recent one, and then I can click on it and go look at any previous ones on that patient. And many other widgets, home medications, the patient's vitals. You kind of get the idea there. So you can create your summary screen to be how you want it to look for you. You don't have to go to IT to do this either. There's a little cogwheel up here at the top. You click on that little cogwheel and you decide what widgets you want on there. You may say, you know, I want my visit history to be above the My widget. Well, you can just move it around, or I can add widgets. So I can type in items in here and pull up different widgets that are available to customize my home screen. So that's what you'll see here. Now you see my visits have moved to the top, and my widget is here a little bit lower. The content of the My widget can also be done on the fly. I'm going to show you that as we move into another section here within the patient's chart. If you want to go look at the patient's diagnostics, let's say we want to look at Test George's labs, there's his lab. So you can see the trending labs over previous visits. I can look at the hematology, specifically the chemistry or whatever particular item I want to look at. And here's today's visit, obviously, but I can scroll through and look at any previous visits, blood work to trend it. If I want to look at just the white cell counts, I can click on it and see just the white cell counts, of course. If you want, you can select these items and you can graph it. Lots of different things you can do to get a good view of trending of how things have changed over time for a particular patient. If you wanted to have one of these items on your My widget, so let's say, you know, I like to have the glucose on my widget. So anytime I open a patient's chart, you show me the most recent glucose on that patient. All you have to do is you go to that glucose and you're gonna right click on it. And you're gonna right click on the glucose. And when you click on it, it's gonna give you the ability. Sorry, I'm on a Mac, so I just gotta make sure I got the right key here. It's not letting me do it. Sorry, I just gotta get the right key, but there you go. So when I right click on it, it allows me to add that stuff to the My widget. So you can see here the My widget. I'm gonna say I wanna add that sugar to that, the glucose to it. And now when I go back to my summary screen, you're gonna see that it's gonna display the glucose for that patient. So really easy to add these things on your own to your widgets, just by right-clicking over the things that are important to you. All right. Similarly, provider notes, I can go through and look all different previous provider notes on the patient. I can filter it if I want to look at just, you know, surgical notes or cardiovascular notes. You can filter it down to what's important for you. And I always want to show this part because people ask this a lot. If you have your historical information in your client server or your Magic system, you have the ability to access that through Meditech as well. So if I want to look at things once you've gone live that was in your previous system, I can click on the activity log and you'll see here where it says 5.x all visits most recent. This patient I know doesn't have any information in the old EMR system or our previous Meditech because it's not highlighted. But if it was highlighted and I clicked on it, it pulls that information into the chart in the same look and feel, so I can look at the information that was previously on that patient in the old system. So really easy way to look at the historical data or historical information. And depending on how your sites determine what you want to do, old blood work or previous blood work from the system can be brought into the system based upon how much you want to bring in for trending purposes from the previous system. All right, over here on the right-hand column, this is called the reference column. These are widgets as well. So again, you decide what you want over here. If you want the ability to be in the provider notes and be looking at things and see the vitals, or you want to see the problem list or the past medical history, you decide what you want over here on this side of the column as well. All right, well, Mr. Test George here has got some abdominal pain. He's not able to keep anything down. So I think we should give him some fluids. So I'm going to go into order entry. So order entry is very efficient once you've set it up in a way that is efficient. So we've done a lot of work with this because physicians and providers have been really concerned about this slowing them down. A lot of the orders that I have done in the ED is done by medical directive. And then anything else above that, I either get it from my order sets that you see here. This is pretty much the ones that I have in real life. This is the test system, but pretty much the same ones. Or medications or labs. I just select from my favorites list and just select them from there. If you wanted to look them up manually, you could up here. But it's a lot easier to just favorite the items, and then you don't have to go looking for them later on. So if, for example, you want to look at a CBC on the patient, of course, you can type in CBC, find CBC, and then order the CBC, but it's a lot easier to favorite it. So how do you favorite it? Well, I'm going to order a CBC. Everything we order in the ED is urgent, so I'm going to select the little star there, and now that's a favorite. So next time I want to order a CBC, I can simply do that from my favorites list. And I'm going to go back to that to show you that under labs now, you're going to see that the CBC is there that I can add as a favorite. So doing this makes things a lot easier than having to look them up manually. So let's order some fluids on this patient. That can be something that you might think is going to take a lot of time. Right now you might just check off a box or write it out. But you can do it very quickly in the system as well. So I'm just going to click IV fluids. What do you want to give on this patient? I want to give them a liter of saline. I just select that. I want to give them a bolus of saline. And then after that, I want to give them some maintenance therapy. So I want to give them normal saline with some potassium in it at, it defaults to 125. Let's just change that to be different to 150. And then I'm done. Okay, I can submit that. And now this patient has IV fluids, getting a liter of saline, and now getting potassium and maintenance fluids at 150 an hour. Very easy to do. If I want to give this patient something for nausea, it looks like they've had some metoclopramide already by medical directive. It's not working. I want to give them some Zofran. I can either go to my nausea and vomiting order set, which has all of these items in it to select directly from. Or if I want to just type in Zofran or Danzatron, I can do that as well. And I can order it here. So let's give them 4 milligrams of IV Danzatron. And you see that the order goes up here into this Amazon kind of shopping cart. So right now it's sitting there waiting. I could submit it, or I can add other things while I'm going along. So yeah, I give them Zofran, I've given them fluids. I think we should get an abdominal ultrasound on this patient as well. So I can use my favorites, or I can just use a quick key of AUSAB. I know it's all abdominal ultrasound. I'm going to select this one here. It's an urgent. Why am I doing this? I use abdominal pain and vomiting. And I'm going to submit that. And now I've ordered my abdominal ultrasound. I've ordered the Danzatron and the IV fluids. What happens with these orders? The magic in the background, that order's already gone to ultrasound. That order's gone to the nurse's desktop to give the Zofran and the fluids. Anything that's pharmacy related is done as well. And quite often it's quite amazing how fast the turnaround happens. Like before, I used to put the orders in a little box, and then you'd be waiting forever for the clerk to get time to put those orders in the system, and then they'd finally call, and sometimes they can't read your writing, and oh my gosh, lots of different things like that. Whereas now, honestly, I can put a chest x-ray in, and if the department's not completely nuts or crazy, I literally have hit enter, and not even a minute later, I can hear them calling for the patient to go over for x-ray, because it goes right to their tracker. It's actually quite good, and we do have data on how we've seen better turnaround times for these kinds of things. All right, I'm going to go grab another patient here just to get some things started. And this patient's in our acute area. I can see, we have a level 1 coming in here with abdominal blunt trauma. So you can see the pre-hospital stuff coming in as well. And a patient here with chest pain, and then this patient here, Tess Julie, with chest pain. She's been here for 8 hours, and I can see from the triage note that she's had 4 hours of chest pain. And I don't like that the troponin looks like it's abnormal here. So let me take a quick look. Yeah, so her troponin's positive. So I better go see this patient. So I'm going to sign up to her here. If you're working with medical students, residents, different level providers, they can sign up to these patients as well, and it will show here the resident's name or the medical student's name. And then they're allowed to do, whatever level of access they have to place orders, to document, those kinds of things are all built into the system. So this patient here, Tess Julie, we saw that her troponin's positive. I see that she's here with some chest pain. So I'm going to jump into the patient's chart. And I want to review a few things. So you're going to see on my widget here, I see the important things that I want to look at. I see her vitals. She's having this pain. I looked at the EKG. She's got some changes that I'm concerned about. And I'm going to go talk with the patient. So, I go talk with the patient. Now I want to document. So how do we document? We click on document. Now, a lot of the times questions come up about, okay, well, let's say she's in tremendous amount of pain and the nurse wants to give her something for pain, and I'm really busy right now, or I'm tied up with something. Can you do like a verbal order? Yes, you can. We don't want to do verbal orders unless we have to, because it's better to be at the system to look at any kind of conflicts in interaction checking. But we all know that we get busy, and if the nurse wants to give somebody some pain medications, you can give that verbal order, and they can put it in the system. But you will have to sign it off at a later time. It goes up here to your sign queue. So I'm going to do an ED note on this patient. So our ED templates are very simple. We've decided to keep it very simple. We do not have a lot of information with check boxes and pulling in information here and everywhere. You can do that. All of our document templates have 2 different versions. This is the simple version, which just gives a narrative. It gives me my triage note. It gives me a narrative box here to do my notes in. It has an area where I can do procedures, some medical decision making, which I'll show you in a minute, and then where I can do some problems and consolidated plan. So that is the one majority of people use in the ED, and up on the floors, they use the similar one for consults and progress notes. They want to keep it really simple. If you would rather have it pull in the past medical history and the medications and the allergies, we have a template as well with a star version of this one that pulls that stuff in. So it's up to you which one you would like to do. So this patient here, I've gone to speak with them. I have some information. Now I want to document on them. You may have noticed over here on this little widget here, we are using ambient listening now at our hospital. So it's I don't do a lot of dictation into the system, like the voice to text, because I now just bring my phone in and it listens to our conversation and the note shows up on the system. So it's really cool because it does a lot of that for me. But right now we're going to do it with the Dragon. So we use Nuance Dragon DMO. I'm at home right now, obviously, but at the hospital we have microphones attached to every computer, or you can use your phone if you want. It has a mobile app on it, and I just talk to it. It's very quick. You can type if you want, but I can I can say the accuracy of this is excellent. If you talk the right way in terms of just talking your normal rate and speed, you don't try to help it, don't sound like a robot, it's going to nail it. Okay. If you try to help it or wait for the stuff to come up on the screen, that's where it messes up. So a lot of that is just part of how you use it, the education around that. So I'm just gonna put something really quick in there just to show you a live demo. So of course there's always the opportunity for it to mess up, but so I'm just gonna click the button here. Now this is pretty neat because I'm at home. It's gonna go through the cell network and all the way to the hospital, and it's gonna get to my hospital desktop. And you'll see this little bar up here. This is my nuanced dragon bar. That's gonna change color as soon as I press the button here, knowing that I'm dictating. I'll do a quick little dictation here. So I'm pressing the button. This patient is presenting with a 4-hour history of chest pain, period, new paragraph. She's had the chest pain for the past 4 hours, comma, it's described as a heavy sensation, comma, that radiates into her left arm, period, new paragraph. She's had associated diaphoresis with that period. She feels nauseous and had 1 episode of vomiting, period, new paragraph. She has noticed over the past 2 days that she has chest pain with minimal exertion, period. She's also experiencing some dyspnea with it, period, new paragraph. Past medical history is significant for that. Next line, 1, diabetes. Next line, 2, hypertension. Next line, 3, dyslipidemia. Next line, 4, family history of heart disease, period, new paragraph. On examination, her vital signs are stable, period. Next line, respiratory exam, colon, good air entry bilaterally, no wheezes or crackles. Next line, cardiovascular exam, colon, normal heart sounds, no murmurs. Next line, abdomen, colon, soft, not tender, period, new paragraph. Investigations, next line, EKG shows some ST changes in the anterolateral leads. Next line, her troponin is positive, period. Next line, depression implant. Next line, this patient is presenting with a ACS, period. We're going to admit her to hospital, comma, we'll start on some fondaparinux, period, aspirin, period. We'll ask cardiology to see, period, new paragraph. So you can go pretty fast. We can look at it and see if it missed a beat, but I don't think it did. So it got it all. So and I go usually a bit faster than that, but I don't want to be too fast to make errors in front of you. But you can go really fast with it, and like I said, it's very accurate. Now that's an example of just doing the straight up note. But there's some of this information is in the system. So like the past medical history, I know the past medical history is over here. She has a history of gout, diabetes, hypertension. I can, all the stuff here I just made up. But if I want to bring that past medical history in there, I can do that. You can use we call it formatted data, and I can just pull in her past medical history, and now it's brought it in. So you can see now that medical history is brought into the chart for me. We have templates where it automatically does that. So if you don't want to have to manually bring that in, and you want it to show up there right away, we have templates that do that as well. But a lot of providers like to have just the what do you call it? The ability just to use a narrative box. You can also bring in templates that are important to you, or templates that you want to use. I can show a quick example here. I'm just going to save this note. Let's say this same patient, and you're going to do a procedure on the patient. Let's say medicine comes down and they're going to do, I don't know, a paracentesis, or if you're going to do a lumbar puncture, or even if you want to do your operative note. So let's do the operative note as an example, because we're not going to be able to do an operative patient on the inpatient side of things today, because we're doing more of the medicine side. But let's say you've done a repair of a hip fracture, and you want to do your hip operative note. A lot of those things may have some similarities in the notes that you do each time. You don't have to repeat that each time. So I can just simply, I'm going to say insert my hip operative note. Insert hip operative. And now it's pulled up my hip operative note. That's the one that I use. I have no idea how to do hip surgery, so this is one that's based upon what we've created for others. And then I'm not sure if you can see my camera, but there's a little button here, and I can essentially just change the things in there. So subtrochanteric femur fracture, that sounds good. And then you press this button, and I can move down to the next one. Post-operative is the same, or I can change it. Like if it was whatever, if it was something different than that, I could change it to humerus fracture. So that would not be good if you went in for that and came out with that. So So you can go through it and you get the idea. I can move from different sections that I have created that are going to change based upon the procedure that I'm doing. So that's another nice way of making documentation really fast and really efficient. All right. We're going to discharge Mr. George before we go ahead and move to the inpatient side of things. So I'm going to go back to this patient, Mr. George, and go into his chart. Sorry, I hit the wrong button there. And as we said, we've given him some fluids. He's had the Azofuran. I'm happy with that. His blood work was not too bad. We reviewed the blood work. A little bit of a white count, but everything else looked okay. I'm going to look at the nurse's notes up here, review the nurse's notes. I can go in and take a look at the vital signs and what the nurse has said about the patient. It looks like the patient's well, they're tolerating fluids. So I think George can go home. So what I'm going to do now is hit the discharge button. And literally what we do is I just hit this button here called Ready for Discharge at the very top of the screen. We put in a discharge problem. It's recommending abdominal pain because that's what the patient came in with. But if I wanted to make it more specific, I can either choose from my favorites that I have here. So I can, pick up vomiting or pick whatever one that I normally use, like nausea and vomiting. So I'm going to pick that one. Or I could search it through the ICD-10. We use IMO, so you just can type in whatever you want. If it's a headache, and select headache as the diagnosis. Hit OK, and I'm done. So now I've discharged this patient. What happens is the nurse will get notification on his or her tracker, and then they'll set the patient up for sending the patient home. If I want to write prescriptions and stuff, I'm going to show you that on the inpatient side of things I can. To be honest, at most of the sites, we still do our prescriptions on paper and just document that we've given them these one-off medications. If they're more than a one-off medication, then we will use the system because we want to make sure that's documented. So pretty quick, in fast track areas where we see a lot of patients, you can do this quick. I use ambient listening, so I'll go from room to room to room with my ambient listening, and then I'll sit down, open the chart, and put the note in the patient's chart. So lots of different ways to make things efficient. So let's go back to Test Julie. I wanted to illustrate one quick thing from the emergency department perspective, is how fast you can do things like, let's say, vasopressors. Now, Julie doesn't need a vasopressor here, but let's say her blood pressure was dropping because of her heart attack that she's having, and I need to get some vasopressors in her to get that blood pressure up. So essentially, I'm just going to click my favorites here for critical vasopressors. It's going to ask me, what vasopressor do you want to give? Do you want to give a levofed or norepinephrine, epinephrine? Do you want to give some push dose, phenylephrine? What do you want to give? I just want to give norepi. And I just do the protocol because I'm all stressed out right now. Just do what needs to be done. So I just select that and I'm done. So I've started the levofed protocol. And this protocol, of course, gives the nurses the parameters. I can change them if I want to change the parameters, but this is what our hospital site uses. So it follows their protocol. I just select it and literally I just hit submit, and now the norepinephrine orders are in there to start the vasopressors. Okay, so really quick. To do some of these things. Tons of order sets here. Everything you can think of, from migraines to nausea and vomiting to lumbar punctures, you name it, it's in there to make ordering quick. Let's admit this patient. How do you admit the patient? So I want to admit this patient to the hospitalist team. So what do? I'm going to consult the hospitalist team or consult the cardiologist. So let's just do cardiology for this one. I'm going to consult cardiology while you're consulting them, because this patient has a non-STEMI, and I'm consulting, whoever your cardiologist is, so Dr. Woolridge, okay? And did I speak with her or not? That's important we have that, because in the ED, we're not allowed to obviously admit people unless we have an accepting MD, so you would say yes. The only time we would say no here is usually at nighttime when we hold them overnight and then talk to our consultants in the morning. So we'll say no, and then we'll notify in the morning. So now I put the consult in for cardiology. So normally I would speak with him or her and they accept the patient. And if I'm doing the admission or they'll come down and do the admission, the process is fairly straightforward. I'm gonna select here, transfer admit. Right now, the patient's sitting in the emergency department. Where do you want to admit the patient to? So we're going to admit them to a medical floor. So depending on what floor you guys have for your particular patients. And then it's going to essentially want me to say, this is what's been done in the ED, and this is what the patient's home medications are. What do you want to do with this before you do the admission? So essentially, I know that this patient takes aspirin at home. I want her to continue that, okay? I know that the patient takes her amlodipine, 5 milligrams. Her pressure's been low, so I'm going to hold the amlodipine. I want her to continue with her Crestor, yes. And then the candesartan, she's on 32 milligrams. I want to continue that, but I'm going to drop this down a bit. I'm going to drop her down to 16, okay? And this is important because you're going to note that when we discharge the patient after her inpatient stay, this is going to keep track of the fact that she came in on 32 milligrams of candesartan and you changed it to 16. So it keeps track of that for when you go to do the discharge medications. Now it's going to ask me, what do you want to do? And her Pantaloc. We'll continue that. It's asking me what you want to do with the norepinephrine that we started. Well, her pressure is good now, so we're going to stop that. She doesn't need that. And I'm going to stop her fluids because she's tolerating fluids. So now I'm going to go in and put in my admission orders. And once again, we just use an admission order set. So if you're going to use, this is a non-STEMI, so I can either look it up or have it favorited. This is my non-STEMI admission order set. It's based upon what's best for patients based on guidelines and best practices. So I'm going to admit the patient. The patient's going to be admitted here to medicine. This normally will pre-populate so that I don't have to enter that information again. The attendant's going to be Dr. Woolridge. Once again, a lot of this will be pre-populated, and the diagnosis is non-STEMI. MRSA, VRE screen, our hospital makes us do that for everybody who's admitted. So some of the things that are pre-checked are things that you may have to deal with. If you're admitting the patient and you want to hand it over to your colleague in the morning, you can simply do that here. I could select physician handover and say that at 7 o'clock in the morning, hand over this patient to Dr. Smith, because I'm just admitting the patient tonight, and then Dr. Smith is going to take care of the patient tomorrow. What kind of diet? Please checks the regular diet. If they're diabetic, obviously, I could select a diabetic diet right here. That starts with lunchtime. And then you could specify these things if you want in terms of the diabetic diet. Cardiac monitoring, telemetry, you get the idea. All the information is here for what I want to do, but now it comes to the medication. So I want to start this patient on Brilinta. So I'm going to select Brilinta for the first dose, and then the maintenance dose for Brilinta. And I want this patient to be on some fondaparinux. So I'm going to select the fondaparinux right here. You may use something different at your site. The order sets are customizable to that. And then it's reminding me about VTE prophylaxis and those kinds of things. So I can select that. All the information, once again, medications that you want to choose are all listed here in the order set. So I don't want to bore you with that, but once again, very quick to put all those things in. And then I'm going to submit. I see I got a conflict over here, so there's something it doesn't like, and it's because of the duplicate therapy. It's because I had already given the patient aspirin in the ED. That's okay, I'm going to override that. And I'm done. So now the admission is done. You see the little yellow flag here, and that means that you've done it successfully, essentially. And the appropriate people are made aware of the admission. So I can move on and go see more patients, and this patient will then the nurse will be notified of this. The nurse will be able to process those orders, start what needs to be started while the patient's in the ED, or if it needs to be just started up on the floor. A lot of our patients stay in the emergency department, unfortunately, in hallways, so they will activate this admission even when they're in the hallway in the ED and get those things started. But from our perspective, the patient has been admitted. So before we move on to the inpatient side of things, I wasn't sure if there's any burning questions really quick about that aspect of it. I know we were going to leave them all to the end, but I wasn't sure if there's opportunity if somebody had a quick question about that. I see there's a lot of things in the chat, so that's good.
She's doing an excellent job staying on top of everyone's questions. I think everyone's had every single one of their questions answered so far. So
good. Yeah, it's definitely not her first rodeo either. We've done this many times. Okay, so now the patient's been admitted, and I'm going to switch hats, and now I'm done my emerge shift, and now I'm going to be upstairs on the inpatient floor as the hospitalist and cardiologist. So I'm going to change to acute status board. So I'm going to hit acute status board, and now I'm on the inpatient side of things. So you notice it looks the same, right? I still got my buttons up at the top, and I got my patient tracker, and I got my workload over here. Exactly the same. So patient tracker here, once again, can be customized for your site. So what we have here is what it's in the test system. You're going to customize it based on what you think is important for your site. I can see Test Julie. Here's the patient that we just admitted with her non-STEMI. She's under me. I guess I'm right here, Garnis. And I can see this other physician's here is the cardiologist. So you can see who the care team is and the family physician, who they are. The information's here, the resuscitation status is here. I can see that there's some blood work back on the patient. These are the indicators. So you can see, for the example, a patient above it, it turns red, that there's something back on the patient. I can click on it. I can go look at that blood work, review all this stuff, even before I go in the patient's chart. So very similar to the tracker that you saw in the ED, just a bit of a different look and feel. You can also select any other trackers you want. So if you want to go look at your like a different floor, or your recent activities, or your consultations that you may have to you, your surgical list, look at your surgical grid. If you want to see what cases are on your surgical grid, you can look at all that stuff from right here by selecting that particular rounds list or patient list. You can also cover for people. So let's say you're going away for the weekend and you want your colleague to take care of your patients for you over the weekend. Well, you don't want to maybe necessarily hand them all over or change the MRP all over and all those kinds of things. You can just sit here, click this little person here, and go edit coverage, and you can say I want to add a provider. So I'm going to unclick this one, but these are ones that I've used before, or you can search them up and say, you know what, this is my team of cardiologists, or this is my team of hospitalists. No, Dr. Giroux, do you mind covering my patients for the weekend or for tomorrow because I need to go away? I just have to, Dr. Giroux would just have to select this, or I would just select that if I was covering for Dr. Giroux, and now his patients will show up on my rounds patient list. So now I can see his patients, so I can follow those and do things that need to be done. And then I can toggle back and forth. So here you see there's two people now because it tells me I'm covering for somebody. So if I undo it, now I just have my patients, and then if I hit it again, it's going to toggle to show me people that I'm covering for. This is really nice because we often use this for something called provider teams. So if you want to have teams, that's the geriatrics team, the hospitalist team, you name it, whatever team you want to have, it's a nice way of breaking your patients up like that. So I have my rounds list, and I also maybe do palliative care. Maybe I do, pain medication or a pain service or what have you. And I want to see just those patients, I can select that particular team. So if I want to see my palliative care team on this list as well, I can select that. So that's nice. So now I see my patients as well as my palliative care patients. If I want to see just my palliative patients and not everybody else, then I can simply go to my provider team list and see just those patients that are my palliative patients. So lots of ways to organize how you want your patients to look to make that efficient. I'm going to go back to my rounds patients. And here's my patient Test Julie. I keep hitting that wrong button, sorry. Right here. And I'm going to jump into Julie's chart. So I'm just going to hit the chart button. And you're going to notice it looks the same because now I'm back in the patient's chart. So once you've gone into the patient's chart, everything is the same for the functionality. The only difference is how you got in there. So in ED, I got in there through the ED tracker, and in inpatient side of things, I got in from the acute tracker. What is different though is my summary screen can be tailored based upon how I enter the system. So if I enter the system from the ED, my widgets are going to show how it likes to be when I'm an ED doctor. Or if I'm an orthopedic surgeon, how I like the widgets to look when I'm an orthopedic surgeon in the ED. But if I open this screen when I'm an orthopedic surgeon on the floor or a hospitalist on the floor, the widgets will change based upon how I want that information to look when I'm in that setting. Similarly, when I go to the ambulatory, which I'll show you, what I want in the ambulatory setting is a lot different than I want on the inpatient setting. So you decide how you want your widgets to look. And it'll remember that based upon how you're entering the patient's chart. So, this patient she was admitted with the non-STEMI. I can go through and look at my cardiology notes, or look at the ED note I did on her. I can review investigations, so I can see what her blood work had shown, or I can place new orders. So if I wanted to place an order, maybe I want to put her on some metoprolol because her heart rate was a bit high. I can just look it up manually, or I can look it up from the ACS order set. I'm going to give her some PO metoprolol. Let's put her on 25 milligrams. And if you want to consult, physiotherapy or do a chest X-ray and follow up, very easy to add these things. Chest pain. Okay, so that's very quick to add some orders there. And I want to now document on her. So documenting, you're going to use like a progress note most likely. And let's say you're the hospitalist. So you're going to select a hospitalist progress note. And you're going to see it looks the same, right, as what it did in the ED. I have my narrative note. There is the progress note with a star beside it. If you use that one, it'll bring in the meds and bring in the allergies if you want to do that. So a lot of our hospitalists and internists and consultants will just use this one here. They'll place their note in here. So whatever you want to put in there, I'm just going to put something really quick. This patient was admitted from the ED with chest pain period, was found to have a non-STEMI period, troponin was positive period, was started on fondaparinux and aspirin period, Paragraph. She's doing well today period. Okay, so you put your note in there. And what I'm going to show you now is what a lot of our hospitalists and internists do to follow the patients along and the family physicians is they will put problems in it, they're problem specific. So they're going to add a problem. And for her, non-STEMI, because that's what she has. So they're going to add that non-STEMI to her document. But they're also going to say, let's say she's developed, some vomiting while she was in hospital. So I can add vomiting as well to my problem list. And now my documentation shows the non-STEMI, and it shows the nausea and vomiting. Some physicians like to document by problem, and some physicians like to document by a consolidated plan. So it's up to you how you want to do it. If you want to go into each individual one and say, continue the FONDA, the ASA, whatever you're going to put for your note in there, and for the vomiting, you're going to give her some Zofran and fluids. You can do that. Or if you want to summarize it down here in the consolidated plan, you can. Why would you want to do this? Why do you want to take the time to use the problems plan rather than putting it just in the narrative box? It's because I'm going to show you what happens downstream, how this will help you with your next note and with your discharge summary at the end of the patient's stay. So I'm going to sign that, and that's filed away. Now, if it's the next day, now you're seeing the patient for the next day and you want to do your progress note today, when you go to do your progress note the next time, now that you have your problem list and your information in there, when I pull up my progress note this time, I can just hit view previous and I can recall that information. So I can hit view previous and recall what was done from the previous note. So you can see now there's the information for the previous note, and now I can just change it. I can change whatever is different on the patient. I'm not cutting and pasting, and now I'm just changing what's different. How her stay is doing now, maybe she's doing better, and I think she can be discharged home or needs another day. So you can easily update your note and your problem plan just by viewing the previous ones. If you have a whole week's worth of notes in there and you hit view previous, you can actually scroll through and review the problem and plan for each of those notes over the patient's stay in one screen. So here I only had one, but if I had 3 or 4 different notes in here, I'd be able to review all the assessment and plans over a period of time. In fact, you can actually review anybody's plan. So if the cardiologist or the surgeon or somebody else had their assessment plans, you could select it here and see all those assessment and plans as well. And if you wanted to steal from it or add information to it, you can do that in your own note. yeah, so I'm gonna save that. I wanted to also add that in the order entry area, and I just kind of forgot to mention this because this is an important one. If you have an order set, so let's say, for example, I'm going to pull up the hip fracture pre-op. So this is, all based on QPBs and best practices and all that kind of stuff for the admission of a hip fracture. But everybody's a little bit different. So if, as a surgeon, I like to do my admission a little bit differently than my colleague, well, you can save this as your own version of the order set. So you don't have to do this every single time. So if your wound dressings are a certain way you like to do it, you just put it in there once. And then what you're going to do is you're going to save this as your own version of the order set. Okay. When you do that, next time you go to your favorites here, you're going to see, for example, how I have Derek's lumbar puncture specimen management. But you can name it as, Dr. So-and-so orthopedics hip fracture pre-op set, because it remembers that's how you like to do it. So next time you admit a patient, you just select your version of the order set, and everything that you've checked and done before, be it dressings or what have you, are going to be there. So I have some orthopedic surgeons and ID specialists who have multiple versions of their order of an order set based upon what the procedure is, because their dressing changes or what they do is different. So they've took the time, tailored them to each individual presenting complaint or procedure, and they just pull that up. So that's a really nice part of this, is being able to tailor your order set. So I just want to kind of mention that. Now, this is from this, there's rules around this, of course, in terms of how that's done and what's allowed in terms of what you can add and what have you. But usually what's on the order set, you can modify and change. If you want to add things to the order set, there's a process to go through to ensure that things being added are appropriate within your formulary. And usually if something needs to be added, everybody can probably benefit by having it added. So that goes through a regional process. All right. So this patient here now tests Julie. She's doing really well. She's developed an allergy to, let's say, the morphine when she was in hospital. So if you want to add allergies, it's very simple. Just click on here and you can add the allergy yourself. Obviously nursing can do it too, but everybody uses the same system. So everybody has access to these things. So I can put in that she has an allergy to morphine. She had an intermediate reaction. She had anaphylaxis, okay? And then save it. And now that's been added to the system. So now she has the morphine allergy added, okay? Similarly with the problem list and the home medications, all this kind of stuff can be edited by you. When we go to discharge the patient, when you go to discharge the patient, you're going to have the opportunity to reconcile what has been done in the hospital, okay? I got to get out of here. I got to go into the discharge. I'm into the wrong spot, guys. All right, so when you go to discharge the patient, you're going to go into the discharge summary here, and it's going to give you the ability to start populating the discharge summary even before the patient's discharge. So if the consultants want to put information on here as part of the discharge plan, or the physiotherapist or allied health, they can go in and start populating this discharge summary even before the discharge happens. So we all know when you start the discharge planning is at the time the patient's admitted, right? So you have that ability to do that here. People can contribute to it. It's not until you actually place this discharge order right here that the patient's going to be formally discharged, when the nurse gets the go-ahead to go ahead and discharge the patient. So I'm going to click on the prescriptions here. So part of the process of discharge, other than selecting discharge, is you got to reconcile the home medications and reconcile what's going on. And this is what is really nice in the system. It's increased our medication reconciliation rate. I can't remember the exact numbers. Julie might be able to throw it in the chat, but we've gone from dismal rates to very high rates, having gone into the electronic system. So this patient's aspirin, we gave her aspirin while she was in hospital, right? So I'm going to stop this one, and I'm going to have her continue her aspirin at home that she was taking. She was on amlodipine 5 milligrams when she came into hospital. We continued it. We didn't change it. We're going to continue that. Okay. The candesartan, the 32 milligrams, she was on 32. Remember, we changed it to 16. Unfortunately, the reason why it doesn't say 16 here is because in the background, the nurse, although I put the order in, it was never administered or changed in the background. But normally that would show that this was a change. This was changed to 16. In real life, that would have shown that, and you would have known, okay, yeah, that's right, we changed it to 16. So I'm gonna go in here and change it for you just to kind of illustrate that. So it would have shown that. And then it lets you know that this is a change from what the patient was normally on, and that they're going to need a prescription for this because it's different. Okay. Whether or not I'm going to continue the fondaparinux, these are the things that I gave her in hospital. I'm going to say no. I'm not going to continue the morphine. No. I'm not going to continue the nitro, and she can continue her Pentaloc. So I've quickly reconciled all of that. And you probably remember I did add metoprolol to one of her medications. Like I said, in real life, the metoprolol would have showed up on this side here for me to continue it as as a discharge medication. It's just that since in the background the nurses and stuff hadn't processed that order, it doesn't show up on here. If I want to add any new medications, I can do prescriptions for medications here. I can, quickly go into my favorites. If I want to give her metoclopramide for whatever reason, I just select it here. Now it's going to do the prescription for metoclopramide every 6 hours as needed with 30 pills. You can create these favorites so you don't have to manually put in these prescriptions. Once you have your set prescriptions, you just select them. Or you can look for the prescriptions and search them in the drug catalog. So I can look up anything here that I want in terms of medications and prescribe them, like metoprolol and things like that. Okay. And I preview it and I see what I'm doing. So the patient's going to get something that looks like this. They're going to say, these are your new medications. This is what you're going to continue. This is what you're going to stop. This is the things that you're not going to make any changes on. I submit that. I have to, fill out some of these things that have some information here that's wanting me to fill out. But you would go through that, put in the quantity of tablets that you want to give the patient, and go through and fill these things out. And then in the end, it's going to populate my prescriptions. I can finalize it. And then when I go to discharge the patient, I just put in my discharge order and the patient's now discharged. What happens now? The nurse, whatever process you have in place, he or she is going to print the discharge packet. It's going to print off their prescriptions. The physician will have to sign it until we get to prescribe IT, when it will go automatically to the pharmacies. And then follow-up information and what have you can be all put on this discharge plan. The physician obviously needs to do a discharge summary as well. I just want to quickly show you something here with that, because if you are using the problem list, your discharge summary can, a lot of it can be pre-populated for you. So going into the discharge summary, it's going to bring in the things, what's the most responsible diagnosis, who the most responsible physician was, what problems were affecting stay. So I can click on here and select the things that were related to that. Here's the problem list for things that the patient had. I can add or remove these problems. And I can hit view previous and look at the notes from those previous notes and select what I want to bring into here. So you can really make the discharge summary process efficient. And we found that we've gone from a lot of patients not having discharge summaries done, or they end up being deficiencies, and 3 months later you get it, to people doing them right at the bedside. So discharge summaries done before the patient's even discharged. In fact, I should have shown this. Our workflow is that they open a discharge summary, and at the bottom of the discharge summary is the discharge prescriptions and plan. So we recommend they don't necessarily use the discharge button. They open a discharge summary. It then opens the document, so it's been started. You put in your discharge summary, you can put in your discharge order, and then if you don't have time to finish the note, you can hit save. The patient's discharged, but now your note is sitting there waiting to be finished. Okay, so you can go in and finish it when you have a chance. But we have found a lot of people just finish their note at the patient's bedside, and that helps a lot for deficiencies and not getting deficiencies to your mailbox. Of course, you can search the patient's chart. Like there's a lot of functionality in here we can go through. There's flow sheets, which the flow sheets are really something that ICU and medicine and the hospitalists use, because you can look at trends of the patient all on one screen. So here you can have all their blood work, their nursing notes, their imaging, their intakes, everything you want in a grid format. So some of our physicians will have this on one screen, and then they'll be documenting and placing orders on the other screen based upon what they see on this grid of information. And you can also interact with the grid. So if there's something on the grid you want to reorder, like blood work, you just right-click it on the particular item on the grid, and you can reorder it just from clicking on it. And lastly, I just want to show you very quick, and then we can open it up to questions. Is the ambulatory screen. So if Tess Julie was booked for a follow-up appointment, you can then jump into your ambulatory clinics. And it brings up your ambulatory schedule. And I see that we've booked her on Friday for follow-up at 10:30 in the morning. So here she is here. And then when it comes to be that clinic day, I just click the chart, and now I'm in her chart again. So as you can see, it looks the same. So now I'm in the ambulatory setting. This would be the ambulatory follow-up setting. So that's a quick run through the system of going through the different modules, and hopefully being able to show you that things can be done very quickly, especially with documentation and order entry, which are the two biggest things physicians and providers have concerns about. We went live and had 90% CPOE rates in the ED and on the floor right away. All of our sites across 23 are very high CPOE rates. And documentation electronically, we don't have any back-end documentation anymore. In fact, our transcriptionists are not being replaced after retirement because everybody does front-end dictation. Even the ones who said they would never do it, do it now. So documentation is done all front-end, and we don't have any back-end, and that's pretty much the same across all of our sites are finding the same, that there's no further back-end dictation. So yeah, we'll open it up to questions. I haven't had a chance to see the chat, so I'm sure there's been lots of great questions that have come through there. There's a lot of other things we can show you, bells and whistles, adding photographs and pictures to your notes, and all kinds of different things that we haven't had an opportunity to show you in the system. Our medication reconciliation rates went up really high as well, and that's part of Accreditation Canada. And it's don't get me wrong, it's you have to get used to how to do it, and you have to have somebody who puts those medications in there. So you have to have workflows to get the best possible medication history in there. Physicians don't have time to do that. So one of the things you're going to see is that in the ED, you have to have a full-time person who puts a full-time person, and it depends on your volume. We have a full-time pharmacy tech who does our BPMH, so that the meds are put in there. So a lot of those things are the workflows you're going to have to really think about. And I think, having seen the demo, one thing you want to do between now and moving forward is think about how you will do your workflow in the system, having seen this briefly, because that's what's important, is how you do your workflow. Any system, you can put in documents and put in orders. It's how you modify the system to work for you. I'm not sure if there's hands going up. I have to open up the other screen to see the people. Let me see.
There are no hands going right now, and Julie has done a fantastic job of answering all the questions in the chat.
Okay, the other thing I want to mention is Connecting Ontario. So when I'm in a patient's chart, I can launch directly into Connecting Ontario just by selecting the button here. So this will launch me into Connecting Ontario. I can also launch into Seamless MD. It's a third-party application we use for our post-operative patients who go home. They can contact us and follow through remote care monitoring through Seamless MD. So this jumps right into their chart. Connecting Ontario. I showed you how you can access the old information in the previous Meditech system. Lots of different ways to get information.
Go ahead with your question, Sandra.
Wondering, I know someone had put this in the chat as well, but about the ability to do some of that customization ahead of go live. So one thing we've been talking about was, you know, the importance of making it your own and customizing it. So how much of that can be done before the system's actually live? Can you talk a little bit about how to do that well?
Yeah, great question. In terms of customization, so once again, first of all, workflows are the key thing. So making sure you have your workflows done. When it comes to the physician's customization of the system, we have over having done this with so many hospitals now, we have a really good idea of what people want on their summary screen from different specialties. So you will start off with a default best, what we think is what appears to be the best widgets for you to start off with for ED for your specialty. And then you can change them yourself at that time, that you can move them around and change them. In terms of your favorites and those kinds of things, the time that you can really do this is when you're in the live system. You can't do it in the test system ahead of time. So some hospital sites have been pretty it thought of many different ways, neat ways of doing this. So they'll have, before they go live, they have the ability for physicians to come into a session, sit down with somebody, and start pre-populating your patients, your favorites, because you have to be in a patient's chart to do that. So they'll have test charts that you can go into to start pre-populating your favorites and pre-populating your order sets. I think that's a really, really important thing to do, and I think it worked really well for the sites that did that. So you have little workshops and stuff to be able to get people in to start pre-populating that information. And just to let you know what we saw today, and Julie can comment on it, but from the nursing perspective, exactly the same. So they're seeing the chart the same way you're seeing the chart. They're seeing the trackers the same way you're seeing the trackers. So everybody's kind of using the same system, if you need to help each other out, so to speak.
Dr. DeBaker, go ahead.
Oh, hey, it's Peter. That was a great presentation. Thanks a lot. And, as we're moving into this, we are right now, trying to assemble our physician leaders for all the various institutions. And I was wondering, based on where you guys had problems with implementation, like I'm not sure what the biggest problem areas were, but what advice would you have on who we should choose? I'm representing our post-acute care where, we have rehab hospital, but a lot of outpatient different programs scattered across the city. And so I'm just wondering what kind of people should I be looking at to get on my team?
Yeah, great question. And this is when I started, that's the thing I was trying to stress is that, you need to get providers involved. And that's what's going to make this, most successful is having everybody engaged to help make the system work for them. So I would never turn anybody down who's, puts their hand up that want to help out with the system. There's always a way of doing it. But you're going to find those people that are more, tech savvy, so to speak, but you don't have to be, but really have an energy and drive to want to do it. You want to, talk to those people. But I also found I listened to the people that were often the loudest and the ones that were, not really happy about the system and didn't feel like the system was going to be, helpful. It wasn't going to work. It's going to slow them down, those kinds of things. And when I had those people, and had them sit down and worked with them and try to, learn from what they have concerns about, because often they have the best concerns. And we made a lot of changes from some of the loudest people that spoke the loudest of problems, of concerns. And when their colleagues see these people actually start to adopt the system or be, positive about the system, it speaks volumes, right? So sometimes finding those individuals as well, it can really have a big impact. I was telling Sandra earlier that we do have opportunity for, I hold a CMIO boot camp. We've done that for all of our sites, for the leaders and CMIOs to kind of go through how to be what is a CMIO? What is a physician leader? We talk about change management that's specific to physicians, why physicians are often the hardest ones to get through change management. We go through all that. We go through a bit of system architecture and basics 101 of how Meditech works, so you have a better understanding when you're working out workflows and things like that. So lots of opportunity for gaining more knowledge around that.
Hey, thank you for that. I don't see any more hands. Oh, Dr. Virioki.
Yeah, I just I wanted to say thank you again for doing this. I think you've managed to alleviate a lot of fear and probably generate a lot of excitement to the physicians in this region. Many of the questions that have been asked of you and on the chat today, I've been unable to answer myself, so this is very much appreciated. I'm sure there will be further questions coming that might be forwarded your way to help us manage things like this in the future. But as a first step and to show regional physicians what's appreciate this very much.